Welcome to session 5, Interventional MRI. So why don't we just dive in and get started. Our first talk this morning is entitled MRA and Pre-Procedural Planning for Endovascular Interventions. It's going to be given by Christoph Karmelnik from Houston Methodist Research Institute.
Does it work? Yeah, it does. All right. Thanks so much for the kind introduction. It's a pleasure to be here, to be invited to give a talk, and looking forward to start the session off. So, this is I couldn't help putting in this picture of the Texas Medical Center from 1950 to 2025. It's quite impressive over a short time how this has grown. Well, I didn't come in 50, and I'm here for about 20 years, so I really saw part of it grow, and it's impressive the resources and the interest there that exists in imaging, as well as, of course, any other medical technologies. And when I came to that, I was actually approached by a vascular surgeon. And the question was, can you actually show me how to intravascular treat, so pre-procedural treatment planning for aortic dissections? And we all know, right, aortic dissections with the septum, right, movable septum, or maybe later the chronic septum, right, provides difficulties for endovascular placement of a stent. So he approached me with that quite some while back. And what we did, we actually, did some imaging here, and you can see it's a simple CNA scan, right? But then when you look at that image, it's basically anatomy, a little bit of motion, but then, oops, too much. But then when you go a little bit further, of course, you have several technologies of MRI that you can apply and that you can utilize in this complex system. So for example, there's phase contrast MRIs shown on the upper left, and you see the flow curves in the true and false lumen. And then from there, you can derive some pressure equations. So you can have between dynamic pressure, total pressure, pressure differences here. You can also then, when you do dynamic contrast MRI, contrast enhancement, you can actually look at contrast arrival times. You can actually see how that goes into perfusion on organs. And the lower right here shows you the kidney perfusion in a color scale, pseudo color scale. One of the kidneys or one of the renal arteries comes from a true lumen, the other one comes from a false lumen. And so you can appreciate just by the simple color scale that there is some malperfusion of one of the kidneys here. So essentially, when you start off, and this was really what I learned in interaction here with a vascular surgeon, what is necessary, what's needed, what's important to use these technologies to actually have some statement about the patient or patient-specific results. Then you can take this a little bit further. And at the time, this was computational fluid dynamics here. And that's shown here in one case here of a chronic aortic dissection. So here we don't have a moving septum. But even so, of course, you can then calculate pressures, total pressures, is shown and then lower there in the center. And I found this very helpful then to talk to the interventionalist and show him additional information or show him some images here, even if it's color only or it's quantitative values, that very nicely illustrate how you can derive from MRI, from anatomical images, with a little bit of help. So perhaps here, as computational methods. The lower right, I have shown 4D flow, but the movie doesn't seem to be running. But never mind. I mean, this is kind of very, very well known that either advanced technology with MRI or utilize computational techniques to extract more information from these medical images. So then just a little bit off here, this has nothing to do with endovascular treatment planning, but we actually did a small validation study here where we used 3D printing. So another one of those techniques, combining that with a clinical question, where we actually then put those in the scanner. We actually had an explanted left ventricular assist device connected with hoses here shown in the setup on the upper left. And then looking at flow, right, 4D flow with MRI on the left and computational CFD on the right. And then on the far right, you see comparison mean velocity, mean volumetric flow, and relative flow. And you can see the different outlets or inlets here, or outlets, I should say, outlets here on that model. And you can see very nice agreement. So that went a little bit into the validation of CFD, something also very, very important that I learned, that you really have to have there if you really want to talk about patient management, patient treatment, or pre-procedural treatment. So fast forwarded a little bit. So that was a little bit in the past. This is maybe a little bit more recent. Probably if you were present yesterday, wonderful collaborator came to us a few years back, her name Tricia Roy, and she really brought a program from her. And also an MRI, Dr. Graham Wright had some part in setting that up, and then charged to actually see, can this be applied here in Houston? And that's one part, how to apply it. And then, okay, how to derive some more information from those images. And this here is a little bit of spin-off of that, using a variational order encoder or artificial intelligence. So what's shown here on the upper left here are on a 7 Tesla Terra, so human MRI scanner, acquired with a knee coil, lesions at the knee, below the knee. And here is, I mean, just next to the knee, I should say, right? There's a lesion here in the artery. T1 weighted, T2 weighted, and the most interesting one is the ultra-short TE. So why is that? Because when you do endovascular treatment planning, you want to get through that lesion, right? You want to be able to cross that lesion. And if it's calcification or if it's collagen, then there are difficulties. If it's maybe thrombus or any other soft lesion, then you can easily cross here. So T2 weighted maybe gives you by, right, by hyperintensity gives you maybe either patency or gives you maybe fatty deposits or thrombus. And UTE dark, of course, is calcium or collagen. So how you combine that? And the first idea was so if you show these three contrasts and you interact, at least I interact with some of the interventionalists or surgeons, they're like, it's complicated, right? MRI, you have to learn about MRI, you have to understand MRI technique before you actually can make a statement. And so the first thing I did was a color composite here. And then what you see here on the right are cross sections here. These are representative either of a patent lumen, so blue, this is T2 weighted, bright, right, patent, and then soft tissue. And this would be when the UTE is actually not dark. So this would be blue, bright blue. And then partially a patent and then lumen mostly occludent down there. So that's one thing. But how, and also interestingly enough, you can then, through amputation, have access to this lesion. So if the amputation is necessary, you can extract that lesion then, and then compare this with histology. You even have a gold standard of histology here. So shown in the center here on the upper row, is actually at 9.4 Tesla now. You would call it maybe MRI histology, and then you compare this with the gold standard histology. So you have a nice pipeline set up here. Dr. Roy set that up. And so you really have a validation here up to the histology from the MRI contrast, from the original MRI contrast. So even so, right, what I explained right now needs some more understanding. And here, making use of what's called a variational order encoder, where you feed in the images. Just a little bit a side note here, we focused on the blue, which is the UTE only. So on the right here, on the top, you feed these images in this algorithm, and the algorithm reconstructs those images, and they come out down there. And that was work mostly done by Judith Surrey here from Semmelweis. And the interesting part is not so much a reconstruction of the images. I mean, you have the images already. It's more like the latent space, and this is in the center here. We heard about the latent space I think at the first day, one of the first talks from the Glasgow group. I like latent space very much because the latent space looks like that. So the latent space here, two-dimensional latent space, will order those images according to similarity. So you don't have to do anything with this algorithm. You feed in the images, you get the images back, you're satisfied they're well reconstructed, and then you look at the latent space. And here the latent space, lower left, patent, right? It's mostly white, so there's no dark, there's no calcification, there's no collagen. On the lower right, the opposite. Right? And then you have partially patent and mostly occludent with soft tissue, upper left, upper right. So then, of course, the contribution, or our contribution then would be, it's not the algorithm to separate these areas into regions and maybe assign a score to each of those slices now. So in other words, you feed a slice, an image to that algorithm, back comes a number. So what you did, you actually translated the complexity, or maybe partially the complexity of that image appearance into a score, into a number. What you can do then for these 5 samples that we had here, they're shown here on the right, in a lateral cross-section here, now with a full color again, right? You can see, you can appreciate the complexity, maybe not the first lesion, right? Looks overly patent, but you can look at number 4, very complex. And then each of those slices is assigned a score, and that's shown below. And then you have the bright bar, right? That means mostly patent. And when you have black or dark gray, it's more complex and more difficult to cross. So you really end up with this algorithm, but just feeding in the cross sections with a score for each lesion. So this is a little bit of what I meant about extracting information from the images, where you then provide a score, a number, a quantification to that. Fast forward that. That was a few years back. Fast forward that now, going away from the 7 Tesla or the 9.4 Tesla, the ex vivo, really going to the 3 Tesla in vivo. And so Judith moved on, and now you have Nico here, mostly from Semmelweis working on this one here. So really trying to see, can this be translated into standard clinical care? So UTE only, so we don't have colors anymore, they're gone, because we focused on blue anyway. And then here, the lateral cross sections here from these different samples. And I have just the numbers, just the numbering here is of course arbitrary. But if you look at the numbers, the A127 and A116 is mostly black, right? That mostly will be challenging. And A95, right? On contrast, 139 here seems to be patent. So again, the same idea here. And this is what the latent space looks now. So we gone away from the simple latent space, right, to a more complex one. Okay, well, here we used colors again. So at one point you have to denote the different regions here. And if you look at the warm colors, that's more like a problem, starting with purple. And the green colors, that's mostly patent, it's mostly go, right? And then you assign color bar next to the lateral cross section for each of those. And what you see here at A127 purple, right? 116 purple, so that's bad, right? 132, but then of course, if you look at the other lesions that are green, right, they're mostly crossable. So again, the same idea, going from the complexity of the images to some color bar, or you could assign numbers to that as well, to a score. I'm very lucky to have Dr. Edelman here because he invented quiz, and so I'm going to talk about a little bit the application here. Interestingly, the question was, can you do it for veins? And still have a little bit of time left. I'm fascinated by this technology, I have to say, because it uses MRI in a very nice way. Maybe not the latest update, this diagram there in the bottom, but it shows very nicely the advantage of this quiescent space, quiescent interval there. That so all the pre-pulses, everything else is done to manipulate the spin system, and then you wait before you do the readout. So you're waiting for the inflow of the blood, you're waiting for everything to happen, and then you get this beautiful, and that's shown in the lower right, this beautiful standard arterial phase here. If you try to do this for venous kiss, and I'm showing you the first, on the left one, the first ones, they're a little bit disappointing, right? But then, of course, you have to be aware, and this is a little bit the message bringing over here. I wanted to, maybe it's just trivial for everybody here, but for me was new, that venous flow is not the same as arterial flow. There are some challenges with venous flow. And on the venous flow, you don't have this, I think, this pulsatile flow that's given solely by cardiac output. And we actually had very good success in omitting this one saturation pulse that's just there to get rid of the signal from fascia, to get rid of the signal from stationary tissue. So we really succeeded to having a little bit of a better image. Of course, once you do that, right, you may have arterial contamination, but at least you should be able to say something about patency of those vessels. That's again something where you start here, and hopefully we will continue with that, maybe also to assign some quantification, some scores to this values. I would also like to mention that I was lucky to actually be able to have access to 5 Tesla human imaging, and that was done on a Jupiter scanner, United Imaging. And here's a new technique, I mean, it's called Fine 2D, so flow inversion non-enhanced, where actually also promising images are available. I'm just going to be curious how to see how this will continue with other technologies, other field strengths, expanding what's already available. And with that, I would like to conclude.
Thank you very much. We'll do the questions in a separate session. Next, Dr. Aravindan Kalandaivalu is going to speak on MRI-guided arrhythmia ablation. Where are we now?
For this talk, I'll provide an overview of the use of interventional MRI for arrhythmia ablation. First, going over some of the shortcomings of a current ablation method, and how MRI might include, although certainly something that remains to be fully realized, and then the current progress of using it. So why does arrhythmia ablation need to be? Ablation is currently the most effective treatment for most rapid heart rhythm. However, some important rhythms, including scar-mediated tachycardia or cardiac obstructive heart disease, has poor outcomes. Thank you. and is a potentially lethal arrhythmia. And more persistent forms of atrial fibrillation, these types of arrhythmias have 1 to 2 year recurrence rates of around 40% after ablation, so there's significant room. So one of the shortcomings of current ablation approaches is limitations in the way we target ablation. VT results from slowed electrical propagation through these channels of viable myocardium that pass through scar tissue, which leads to these rapid circulating reentrant arrhythmias. And the idea of ablation is to transect these propagation channels so reentry can no longer occur. So one of the challenges of targeting VT ablation is that patients who have this scar substrate commonly have multiple regions in their scar that can support reentry. And it's time consuming to locate all of these locations with conventional invasive electrical measurements. And the issue is that if you choose to just ablate some of them, generally whatever was unablated will lead to the next VT, and that's part of the reason for the higher recurrence rate. Another limitation is our current intracardiac electrical measurements are limited at detecting ablation targets that are further from the ventricular surface. So in this example, we see a case where electrical measurements were made across the interior surface of the heart in the typical first-line fashion. However, the map looked entirely normal, so indicated by normal high voltages, purple. But when higher risk epicardial access, so access to the outside of the heart was performed, well, then you could see the scar that was leading to the VT in this patient. A particular issue is that when the scar might be mid-myocardial, then both the endocardial and epicardial maps may appear normal, so it can be hard to determine where to. So MRI could improve ablation targeting because MRI can detect the transmural distribution of scar that contributes to arrhythmia, and is now a pretty standard method of evaluation of not ischemic cardiomyopathy scar distributions, as well as scar distributions in various non-ischemic. However, there's been interest in using this scar depiction, typically by late gadolinium enhancement imaging, to more specifically target VT ablation. Probably the strongest line of work in this direction has been from the Barcelona group, where they applied fairly standard initial segmentation techniques to separate scar into dense scar, higher intensity scar, and lower intensity scar, also termed border zone, on LG images, and then defining the scar border zone corridor features. And they found that by ablating just the corridor features, you expectedly reduce imaging time compared to procedure time compared to performing standard ablation. But interestingly, it hints that it might be possible to even improve outcomes over sort of the standard, more time-consuming ablation. They later reported that outcomes for when the scar corridors are more in the mid-myocardium are poor even with image-guided ablation, and suggests that these cases might be ones where you need different types of or less standard ablation tools. Another shortcoming of current arrhythmia ablation is the limited current ability to assess durable ablation. I'll defer some of this discussion to Dr. Wright's talk. We'll go into this in more detail for the ventricle. But I will just mention that currently, the most studied method for assessing durable ablation acutely using MR is using this native contrast T1 weighted technique, and that the contrast appears, sufficient to detect, necrotic ablation lesions, not only in the ventricle, as Dr. Wright described, but we have been able to see sort of complex ablation topology in the atrium, certainly preclinically. And this technique is starting to be applied clinically, although I think, as we were discussing, there's some variation in the ability to visualize lesions and try and understand why that might be. So the idea of iMRI is to guide complete durable ablation. And part of the benefit of this idea of performing the entire ablation procedure within the MRI scanner is that there's an inherent registration between the device used for treatment, the surrounding anatomy, target anatomy, and ablation lesions. So in this case, overlaying the native contrast T1 lesion. And the idea is that this facilitates being able to accurately guide devices towards sites of incomplete ablation. Now, one thing to note is that typically the interventional device on its own is not very well visualized by MRI compared to the surrounding anatomy, but this device visualization can be improved by incorporating these small catheter embedded coils. In this case, we see sort of a UI depiction where the different coils are color-coded to help appreciate the distal versus proximal portions of the device. And this illustrates, at least, use of real-time imaging, how it might appear in a scanner where you kind of can adjust the device to achieve stable contact. Here you can still see the device a little bit bouncing around, but eventually you can get stable contact with the wall, which is needed to deliver efficient lesion. And then after ablation is performed, could reassess it using imaging. There's several basic requirements to be able to perform interventional MRI-guided ablation. And these were some of the first techniques developed. A lot of this work pioneered by Dr. Halper and Hopkins, who I've been fortunate to be a part of that group for several years. And this includes development of low magnetic susceptibility devices, application of filtering techniques to avoid introduction of EP equipment noise into the MR images, and conversely, filtering to suppress noise and the cardiac electrograms that might be generated during the MR scanning process. One of the most important requirements for clinical translation is the necessity of suppressing RF heating of EP devices. Typically, the RF transmission can lead to heating of the elongated metallic conductors within the device. However, over the last 15 years, there have been a number of methods introduced to suppress heating of the various conductive components of these catheters, and recently, including work from Dr. Schmidt and our group for suppressing the heating on metal braided catheters for devices that can have improved mechanics compared to polymer. And this has allowed a transition from the initial interventional EP cases where we had to very tentatively maneuver the catheter into the heart because we really couldn't appreciate the device tip location. The current situation where we don't have to be so careful about SAR, in this case using SSFP versus GRE imaging, and you can nicely see when the device is moving out of plane, and it can be steered back into the plane. In this case, we can fairly rapidly then maneuver it into the coronary sinus structure that we often pace from for. In addition, these visualization coils can be used for catheter position tracking. This is work from Dr. Dumoulin, which has been critical really for a lot of these interventional procedures, and interviews where you can use 1D imaging in orthogonal directions to derive device coordinates. And by placing multiple coils along the device, you can appreciate the device shape and orientation. Coupling the position information with measured electrograms, you can generate these electroanatomic maps similar to what you might do in a convention. So the initial clinical interventional ablation procedures have been for this rhythm typical atrial flutter, which is a fairly simple reentrant arrhythmia that's confined to the right atrium. And the treatment of this arrhythmia involves ablating between the tricuspid annulus and the inferior vena cava. Typically, this is a curative procedure, even using current ablation techniques. However, it's been used to establish the procedure workflow in the MR environment and for regulatory approval purposes. So the progress towards clinical interventional MRI ablation has largely paralleled the development of these heating mitigation strategies and incorporation into clinical grade devices. However, even with active tracking, it took second generation devices with improved mechanics and better noise suppression and electrograms to be able to reach the success rates that we currently get in standard ablation. And this has led to the current multi-site prospective study, which we're a part of. This prior work has already led to approval, CE mark approval. This study is seeking FDA approval, and it's a multi-site study, including many sites in Europe. And this is for approval of the MRI commercial. So this illustrates our current workflow for interventional MRI-guided ablation. We, and I think most groups, perform vascular access outside the immediate MR scanner area, although not all groups are doing it in a separate EP lab. And a large part of this is there's still limited availability of vascular access tools like vascular access needles and guide wires. There is some hope that we'll transition towards using some MR-compatible version of devices over there. And then the procedure itself, though, is performed in the MR suite. In general, it's very similar to a standard procedure, except that the imaging system is an MRI scanner instead of a fluoroscopy machine. Important considerations, obviously, though, is that there has to be very careful tracking of ferromagnetic items so that they don't get close to the scanner. And non-MR conditional and anesthesia equipment needs to be secured well away from the scanner. So here we illustrate our typical workflow for interventional MRI-guided typical flutter ablation, although these steps parallel any ablation. And so the first step is this pre-procedure planning step. There's not so much of this done in conventional ablation procedures, but it is nice that we can nicely depict the anatomy here of the cava tricuspid isthmus, the target for ablation. And here we can see a couple of variants that often lead to longer procedures when we do them in conventional means and don't sort of see this anatomy. So we can see a prominent eustachian ridge, which generally requires retroflexing the catheter to be able to ablate this region. Here's an example of a long distance between the inferior vena cava and the cava tricuspid, or sorry, the tricuspid annulus, which might require a deflectable sheath. And so these sort of planning considerations could be taken into account before the procedure starts. This information. Here we just see the idea of grossly guiding the catheter into the heart to the general target region using real-time MR guidance. And the nice thing is we can overlay this with the anatomy from an MR angiography. Typically, we use T2 prep non-contrast angiography so that we can perform later non-contrast lesion assessment. There's also electrogram recordings, both surface ECG and intracardiac electrograms provided by the Imricor system, very similar to a conventional ablation procedure. The procedure itself is performed in a similar way, at least initially, in which we track the position of our catheter and mark where we perform ablation. One of the nice features of being in the MR scanner is that if there's a location where you ablate and we don't see the expected electrogram attenuation after ablation, you can also confirm whether the issue might be limited contact. That's an important prerequisite for creating good lesion. And then afterwards, for the study, certainly we're performing an endpoint similar to conventional endpoint where we pace on one side of the ablation line and confirm that the timing of electrograms is delayed across the line and keep that pacing from both sides, which would be a standard endpoint for this type of ablation. But we are also performing this native contrast T1 imaging. And it's, part of this work will be to get a sense of how different imaging features relate to durable ablation in a situation where the ablation is fairly successful. So we can typically achieve durable ablation even with conventional. But all of this work in typical flutter is really prerequisite for the eventual goal of trying to improve outcomes for complex arrhythmia. One of the main limitations in being able to do this in the past has been the limited inavailability, I should say, of MR conditional external defibrillators. These are needed for VT ablation because often we'll induce VT intentionally as part of the localization process, or it may occur spontaneously in these patients who have a tendency for VT. There is a commercial version of this device, which is still in the pre-approval stage, but it is currently used in studies in Europe. And there was recently the first ventricular ablation procedure performed earlier this year, not in the setting of structural heart disease, but for premature ventricular complex. Another consideration in moving towards ventricular tachycardia ablation is that most of these patients who have structural heart disease VT will also have implanted cardiac defibrillators. As I think most folks here are aware of, that these defibrillators can create significant artifacts in the image, and that there are methods now for significantly improving image quality in these patients. And particularly this wideband inversion recovery technique has been very helpful for the late gadolinium enhancement scar imaging in suppressing this hyperintensity portion of the artifact, which is generally previously affected almost all patients. We're also investigating other approaches for mitigating other portions of the artifact, like the signal void and the distortion using local cardiac shim. And so I'll just end by summarizing that MRI is an attractive approach potentially for integrating MR-augmented ablation targeting and lesion assessment to guide completed ablation, and that our current interventional MRI procedures appear close to equivalent to conventional ablation for basic ablation procedures like typical flutter. It does seem that the prerequisite technologies are largely in place for interventional MRI-guided ablation of complex arrhythmia like VT. However, there needs to be ongoing refinement of clinical-grade devices and the workflow for treating these complex arrhythmias, particularly for seeing the eventual goal for the outcomes. Thank you.
Our next talk is entitled MRI for Assessment of Cardiac Arrhythmia Ablations. It's going to be given by Graham Wright from Sunnybrook.
Thank you. And again, thank the organizers for the invitation to speak at this wonderful meeting. I hope you were paying really close attention to that last talk, because essentially I'm going to drill into just one aspect of it. And particularly, I think if MR is going to make a big difference in the EP suite, a lot of us believe that the place where it's going to make the difference is in ventricular arrhythmia ablations. And specifically, what we got to do is bring down those recurrence rates. I mean, there are very few procedures where people are willing to live with a 1 in 3 failure rate, but they are living with that. But that's why it's not first line. Almost always they put the ICD in first, because if you fail and that person goes out and they have a ventricular arrhythmic event, the odds are they're going to die. So so we have to be able to convince them that this is going to be foolproof, and that's why we need to have really good assessment, and that's kind of the motivation for this effort. Working with various companies to move this all forward, and this will be off-label use of GAD. So I think the previous talk already set this up. So what we're mainly focusing on is ventricular arrhythmias and structural heart disease. There's a lot of people now living with prior MIs. They've got scars in their heart, and a lot of those people develop ventricular tachycardia, which is the leading cause of sudden cardiac death worldwide. So, and as Aravindan already kind of set up, the substrate for this in the case of structural heart disease is essentially you've got dense scar. There we go. We've got dense scar, which causes electrical block, and then the action potential wave essentially circulates around that. It has to go through this isthmus, which is a slow conducting region, and that slow conducting region is really made up of heterogeneous infarct, basically a mixture of healthy myocytes and scar. And the way they typically find that is electrically high voltage is healthy, really low voltage is dense scar, and the intermediate voltages are that heterogeneous infarct. And their goal is to go in and essentially carpet bomb that area with and homogenize that scar in that heterogeneous infarct so it no longer allows conduction. So this is a curative procedure, but as was noted, the success rate, even if they identify during the procedure that they try to induce and they don't induce, so it appears immediately successful, the long-term failure rate is 35%. And obviously, again, you can't live with that. So these patients are backed up with ICDs. So we need to bring that number down. So our goal is to develop MR tools to assess ablation success paraprocedurally, ultimately to reduce ventricular tachycardia recurrence. This is just really quick background material that Aravindan already covered. The electrical way of identifying these is with voltages to find the scar. We can do this much actually better with MR. We can identify the dense scar as the really bright regions, the high intensity regions. Healthy scar is the dark regions, healthy tissue is the dark regions, and the intermediate heterogeneous zones, which we think are the slow conduction zones, are those intermediate signal intensities. And we can develop those maps. And the group in Barcelona has shown that they correlate really well with the electroanatomical maps. Now, it's interesting if you look back, it's now been 25 years since the first studies showed that you could actually see these ablation lesions. And again, ultimately, I think the challenge right now is, as I noted in the previous, when they do the ablations, they basically put a little red dot there and they say, okay, I've ablated that area, but they have no idea how much tissue they've actually ablated. But MR can tell them. And if we can tell them that they've really covered that area and that they've created durable lesions, then we believe that that will predict better outcomes. So just to kind of give you a bit of the quick history, when Al Lardo did this early work, first of all, he looked at T2 weighted imaging and did an ablation in this area. This is an animal model. And you can see you get this kind of bright diffuse signal in that area of ablation. In a T2 weighted image, it's basically inflammation edema that you're causing with the ablation. So it's sensitive, but not particularly specific. Went in and threw an LGE and with the gadolinium. And now you can see at the core of that ablation, there's a dark core, so microvascular obstruction, surrounded by a rim of brighter inflammatory signal. So now we've got actually a more targeted area. But one of the challenges with GAD is it'll slowly seep into that central region, so you never know exactly how big that lesion is. One thing that we noticed, and as was noted, there's some work earlier by Dickfield, is that if we just did native T1 weighted scans, we could actually see those lesions pretty well. So here's again in the pig model, here's a couple of lesions. Notice the T2 weighted image, it's kind of very dispersed edematous tissue, so it's kind of bright all around, so you don't know exactly where the lesion is. LGE shows those MVOs in the center, so that's good, but again, exactly how big those lesions. With native T1 weighted imaging, effectively what happens is the area where you ablate gets a slightly shorter T1 than the surrounding tissue. So if you choose your inversion recovery right, you can basically null the surrounding tissue and get bright signal. And why is that? Well, so we looked at the tissue in the area of the ablation. Those are the blue areas versus the areas in the healthy, and there's a lot more ferric iron. Turns out, and this has been known for a while, that if you heat things like hemoglobin and myoglobin up to over 55 degrees Celsius, the ferrous iron turns to ferric iron. So now you've created an inherent native contrast agent, which reduces the T1. So this is what's driving that brighter signal in the native T1. So essentially, we have a marker for when you get heat over 55 degrees Celsius, which turns out to also be about the temperature which kills tissue. So the question of durability. This is some great work by Kolmovsky, I think when he was in Utah. And he basically looked at these native T1 lesions in healthy hearts in an animal model and compared the size of the lesions seen in the MR with then the chronic histology about 2 months later and showed great correlation. Basically, at the time of the procedure, these native T1 weighted signals predict the size of the lesion 2 months later. So we can predict durable lesions with this technique. The group at Hopkins, particularly Mike Gutman, really advanced this effort by turning the scan into a 3D scan, and now we can see these lesions really beautifully with this high resolution information to depict the target. Okay, so what did we do? All of those lesions were done in healthy tissue. We don't ablate in healthy tissue. We're ablating in that heterogeneous scar region in the presence of VT. Well, not during VT. So we created an animal model where we effectively give the animal an infarct with a 100-minute LAD occlusion. We let the animal recover so it develops scar, and about 80% of the time we get inducible VT. So we basically get that substrate with dense and heterogeneous infarct, as you can see here, and we can do those beautiful maps where red is dense scar, blue is healthy tissue, and the intermediate colors are the heterogeneous infarct, and we can use that to target where we should be ablating. So can we ablate in that heterogeneous infarct? Answer is yes. So here's the baseline LGE, which shows that heterogeneous scar. Here's the native T1 weighted images after the ablation. You can see the lesions beautifully, similarly with microvascular obstruction LGE, and here's the histology. You can see we landed an ablation right in the middle of a heterogeneous infarct where you can see the fibrosis surrounded by healthy tissue. Here's an ablation in healthy. So you can see the lesions. Great. That was step one. That was work by Philip Akron. And we showed that the lesions are in MR are comparable with, in both healthy tissue and dense scar, the sizes are comparable with the histology. So we are comfortable saying that yes, we can make lesions in that heterogeneous infarct, and the lesions are the size that we expect in histology. Okay, let's go on to the challenging problem. So let's go to our model of inducible VT. So this is an animal at 5 weeks post infarct, and you can see here that there's this lovely zone of heterogeneous scar that we believe is the substrate of the arrhythmia. It corresponds to the electroanatomical map where we can similarly see those intermediate intensities. So we're going to target that area. This is all done in a conventional cath lab right now. We basically use a CARTO system. We do a bunch of ablations to try and homogenize that heterogeneous scar. And then we take the animal to the MR. And that blue in the next image is the segmentation of the native T1, showing that, well, we basically got the right spot and targeted that area of heterogeneous infarct. More importantly, here's what the scar looks like 5 weeks later, where we've turned that heterogeneous infarct into dense scar. So just conceptually, there's the workflow. It seems to work. So the next question is, are we, like in the study with Kolmovsky, can we show that we get the durable fibrosis in the areas where we did that ablation? Well, step one, we just wanted to check that the LGE and the native T1 were roughly saying the same thing. So we figured out the volumes of the lesion based on LGE and native T1. We saw good correlation. But typically, the native T1 lesion volumes were smaller than the microvascular obstruction. Again, because that microvascular obstruction tends to kind of cover more region than just the heterogeneous infarct damage. So maybe native T1 is more specific. So then we looked at the chronic LGE versus the pre-ablation LGE. We basically did a difference of the dense scar volume, and that difference should have been due to our ablation. So the difference in dense scar volume correspond to the volume of the ablation lesions that we looked at. And here you can see good correlation between that difference in mass, difference in dense scar mass, and the native T1 LGE the native T1 lesion volume at the time of the ablation. So again, we think we can actually predict the amount of additional dense scar you're going to get at the time of the ablation, and we can predict what's going to happen 5-6 weeks later. And this just shows that, in fact, that the volume of the native T1 paraprocedurally predicted that difference chronically better than the microvascular obstruction, the LGE. So native T1 seems to be more specific. But that still hasn't answered the question. Ultimately, what we want to know is, can you predict whether or not that animal is going to be inducible for VT 6 weeks later in a chronic stage? We know that it's likely not inducible at the time. It's probably not inducible because you caused lots of inflammation and you basically blocked all the electrical channels just with fluid. That fluid goes away. So that's our belief is that's probably one of the biggest causes of recurrence after what appears to be an immediately successful procedure. So what we did was we effectively guessed at what the chronic LGE map would look like by taking the pre-ablation LGE, taking the native T1 weighted scar volume, and effectively merging that in and saying that's all going to become dense scar. And so this is what we think the dense scar map is, and now we're going to go look for channels in that dense scar map. We did the same thing with LGE to see how well lesion volume with LGE predicts outcomes versus lesion volume with native T1. And so basically, if in these prediction maps, you see a reentry channel in the target zone, you say that animal is going to be inducible, that animal is not going to be inducible, and then we compared it to a study where we actually took the animal back to the EP lab and tried to induce VT. So the result was that basically we did a kappa test, and that the native T1 and the inducibility study were in agreement moderately well, whereas the MVO versus VT inducibility was a fair agreement. So it seems that native T1 is a slightly better agreement. Now, it's not perfect yet, and there's lots of reasons for that. There's lots of things we still have to control for in the study, but it's encouraging. We're on the board. So we believe that this is potentially a marker of outcomes in the future, so that we can, and presumably then you can use that information paraprocedurally to go and fix things while the patient's still on the table. Okay, but again, that's animals, and nobody believes that animals are humans, at least not right now. And so particularly that the VT substrate is exactly the same. We think we've got a great animal model, but it's not perfect. Anyway, so we've got to go in and do patient studies to see if this works in patients. As Aravindan mentioned, a lot of these patients have ICDs, so that makes life hard. But we have now started, we basically are now scanning patients within a week of their procedures. We've done 10 patients so far. 6 of those 10 patients had ICDs. We were able to give GAD in 9 of those 10 patients. And this is what the images typically look like. So the red dots are kind of the merged electroanatomical map to show us where we ablated. You can see the microvascular obstruction in LGE, and you can see that native T1 highlighted signal in the same area of ablation. This is without an ICD, so we get nice pictures. This is in the presence of ICD, so we can't study the anterior region right now in such patients, but fortunately this person had an ablation more in the posterior region. Again, that's the place where they targeted. You can see the MVO, you can see the bright signal. So again, it's very encouraging. We can actually see these lesions in patients. So, again, the MVO is bigger, the lesions, than the native T1. So I got 10 seconds, so just to wrap up, effectively, that we believe that MR is going to be important for outcomes assessment. The native T1 contrast seems to provide better lesion characterization. In our preclinical studies, we're showing the promise of being able to predict outcomes. We've now shown that we can see the lesions, and now we want to do the outcome studies in patients. That, I thank all the people that have contributed, and thank you for your attention.
Thanks very much. The next talk will be by Dr. Klaus Christian Piper, MR Lymphangiography Techniques, Indications, and Emerging Frontiers.
Well, good morning, and thank you very much for the invitation. I want to give you a very short overview, case-based overview over what we can do with MR lymphangiography at the current state. When we're talking about lymphatic imaging in general, we always have to consider specific lymphatic anatomy and flow. Obviously, the central lymphatic system is a unidirectional system in contrast to the arterial venous system. So the flow always goes from the periphery, from the organs, towards the venous circulation. It works, okay. To the venous angles. So we have to consider that when we do contrast enhanced studies. Which diseases are we actually talking about? Very rough overview, very simplified. We are talking about lymphostatic diseases, basically different forms of lymphedema, about lymphatic leakages that can be traumatic or non-traumatic, more complex lymphatic flow disorders that can be observed in patients, for example, with congenital heart disease, but also various forms of central conducting lymphatic anomalies. And these all can lead to regional or generalized discharge of lymph. For example, it can cause a chylothorax or plastic bronchitis or protein-losing enteropathy. And then, of course, there's a very large group of lymphatic malformations and anomalies. Which lymphatic imaging techniques do we have at our disposal for these patients? Well, on the one hand, we can see larger lymphatic malformations already on conventional imaging. Then there are the older techniques, the oil-based X-ray lymphangiography and lymphoscintigraphy, which have their limitations. And then these newer techniques, MR lymphangiography, in certain cases also CT lymphangiography. And when you're especially interested in superficial lymphatics, you can also perform fluorescence lymphangiography in the periphery. What are possible indications for MR lymphangiography? Well, obviously, the differential diagnosis of unclear edema, but also the localization of peripheral and central lymphatic leakages, and then the more complex cases in patients with suspected or already known localized or generalized anomalies. And in my view, the strength of MR is treatment planning as well as outcome assessment in these patients. I don't want to go into that much detail. I want to show you some cases later. But you can do a non-contrast imaging with heavily T2 weighted high-resolution 3D images, as in this case of depiction of the anatomy of the thoracic duct, which obviously doesn't give you any flow information. And you can also perform contrast-enhanced studies either by intracutaneous interstitial injection in the periphery, so-called, in this case, transpedal MR lymphangiography, or nodal lymphangiography, which gives you more flow information and dynamics. And we don't need any oily contrast agent, which has always been a worry for some referring physicians. When we want to examine patients with peripheral diseases, so lymphedema or peripheral leakages, we currently need interstitial MRL. when you want to get information about the central lymphatic system, for example, in patients with chylothorax or lymphatic anomalies. You can do both, although nodal MRI gives you more dynamic information. These are just some typical examples of the superficial peripheral and the deep lymphatic system of the leg. And this is how the central lymphatic system can be depicted with a nodal MRL, and then you can also reconstruct these 3D volumes to really get an idea of the anatomy of the central lymphatic system in these patients. How well does this work? Well, for transpedal MR lymphangiography, when we are looking at the central lymphatic system in patients with chylothorax, we see that for all anatomical structures as well as the pathology, the accuracy compared to the gold standard conventional lymphangiography is around and above 90%. Nodal MRL is also a reliable technique. This is just a small excerpt from 1 year, 7 years ago, in which you can see that the overall technical and clinical success where you could actually answer the question you had was almost 100%. When we're looking at patients with lymphedema, we're not only looking at contrast-enhanced images, also the distribution and extent of the edema is important, from very mild edema to these excessive edematizations of the superficial tissue. The changes in the fatty tissue are important, and then with contrast agent we can assess lymph vessel anatomy, lymph node anatomy, as well as changes in the dermis, dermal reflux as a sign of a runoff problem with reflux from lymph from the draining system back into the dermal system. And you can also at least perform a semi-quantitative analysis by doing dynamic scans. This is a typical example of a patient with primary lymphedema. You can see these dysplastic, dilated, tortuous lymph vessels in this patient, and this actually looks different from a patient with obstructive lymph vessel disease after it's a patient with a secondary lymphedema. After a groin lymph node dissection, you can see that there are these collectors that then terminate in areas with dermal reflux, and this can lead to dermal rerouting, as in this patient, as a compensatory mechanism. You can see that this large collecting vessel terminates in this area of dermal backflow, and then there are new vessels deriving from there, actually being a collateralization mechanism. And we can then also use these images to guide modern surgical approaches to do, for example, lymphovenous anastomoses. The strength of MR is that you are not only limited to see the immediate vicinity of the problem. This was a patient with a very mild edema, young girl, very mild edema of her ankle. You see these dysplastic vessels on her right leg, but actually when you're looking at the central lymphatic system in this patient, you see these extensive lymphatic masses in her pelvis, in her retroperitoneum, as well as in her thorax. And this was actually the case of generalized lymphatic anomaly. So the edema was at this stage only the tip of a very, very large iceberg. Don't want to go into too much detail concerning lymphatic malformations. Just to give you an idea, this is also a patient with generalized lymphatic anomalies, spontaneous chylothorax and chyloscytitis. You can already see these extensive fluid collections, this altered lymphatic system. And when you look at the flow dynamic, you can appreciate there are several leakages into the abdomen as well as in the thorax. This is a condition that's very hard to treat, and we're currently struggling to help these patients. Central lymphatic flow anomalies are characterized by backflow from the central lymphatic system towards the periphery, and this is not associated with these large cystic changes you see in other conditions. This is just a typical example of a patient with a Noonan syndrome, a rhizopathy, 3-month-old girl with severe congenital chylothorax. And when you're looking at the central flow in this girl, you can actually appreciate that there is no thoracic duct in this girl. Flow goes directly into the lymphatic system of her lungs. So these dilated lymphatic vessels of her lungs and the pleura that cause the problem are actually the draining system. So it's no use to try to occlude these, and we have to think about more complex medical approaches to these patients. But not all of these changes are lymphatic malformations. This is just a case to show you in a patient with cervical lymphedema and a chylothorax, in which the central lymphatic system doesn't look quite normal. It's dilated. We see reflux into her neck. But when you look at the source images closely, there is something in the dilated terminal part of the thoracic duct. And on closer examination and biopsy, it was actually a thrombus in the terminal thoracic duct. And after thrombectomy, the symptoms went away and the system normalized within a couple of weeks. Treatment planning and outcome assessment, also some cases just to give you an idea what we can do. This is a typical case of a patient after extensive retroperitoneal lymphadenectomy, severe chylosositis, as you can see here. And when you do a nodal lymphangiography in this case, you can see that there are already leakages from the iliac lymphatics and an even larger leakage from the retroperitoneal lymphatics without any central outflow towards the thoracic duct. And we can then use this information to selectively embolize these leakages. And in this patient, this led to immediate resolution of the ascites. The question is, does MR really influence treatment? And these are typical examples and nice examples to show you why pre-interventional imaging in these patients is important. More or less the same clinical history, post-surgical chylothorax after thoracic surgery. And in this small girl, you can actually see that there is leakage from the terminal part of the thoracic duct, normal thoracic duct leakage up there. In this case, an embolization or a ligation may be feasible and useful. When you look at this small boy, and although the thoracic duct doesn't look quite normal, it's not the source of the problem. The source of the problem is down here, these paravertebral lymphatics that leak into the left pleural cavity. And in this case, embolization of central outflow, this case, or ligation would most likely worsen the situation for the patient quite considerably. In recent years, things have become quite a little bit more complex by the introduction of new methods to treat these patients or options to treat these patients medically. And this is just an example of a patient again with Noonan syndrome that can respond to MEK inhibitor therapy. And you can see that in this patient with the extensive chylothorax, after 2 years of treatment, the patient, the image looks a little bit better, and the patient is well as well. But when you look at the central lymphatic system, The initial images seem to show you that all these changes have gone away and that the patient has a more or less normal lymphatic system after the treatment. But when you look at the later stage of the examination, with this extensive reflux at the baseline, you can then appreciate that it looks a lot better after treatment, but these changes do not go away completely, and we are not currently completely understanding what will happen in the long run in these patients and if they do need long-term treatment. In my last case, just to show you what extent of changes you can see in these patients, was a small boy, 6 months old, with more or less unexplained right-sided pleural effusion and extensive pulmonary edema. And when you look at the central lymphatic system, you see that it's dilated and you see massive reflux, more or less exclusively into his right lung and his right pleura, explaining the problem. And using this information, you can then do an intervention, occlude the refluxive vessels, and on control lymph angiography, the system has relaxed quite a bit. We see normal outflow, normal calibers, and the patient improved within several days. So yeah, thank you very much.
Our last talk this morning is entitled Cardiovascular Techniques and Applications on UMR Systems. It's going to be given by Yongquan Yi from United Medical.
All right. Thank you very much for the introduction. And good morning, everyone. I'm very excited today to have this opportunity to give a general introduction on the cardiovascular imaging on United Imaging's UMR systems. So yesterday afternoon, right here, we had a very interesting discussion on how to improve the clinical feasibility and applicability of the neurovascular imaging techniques. So I hope that my presentation today can add a little bit useful information to that very topic. To declare, I'm a full-time employee of United Imaging Healthcare in Europe. And we all agree that the cardiovascular imaging is by itself the most challenging category of the MR imaging techniques. So with all its challenges falling under different domains like operational, technical, physiological, and applicational aspects. So I would like to briefly introduce how we tackle these challenges. So firstly, United Imaging offers a comprehensive portfolio of UMR systems from the 1.5 Tesla to 3 Tesla, including the PET-MR, and to the whole body ultra-high field 5T Tesla and the 9.4 Tesla preclinical animal systems. So on each of these UMR systems, we offer a comprehensive and optimized package for cardiovascular imaging. Well, except for the NX Frontier, which is PET-only system that's dedicated for high-end neuro researchers. So in United Imaging, we design and manufacture 100% of all the core components and technologies in-house, including from the superconducting magnet to the full gradient systems, full RF systems, and spectrometers. So by making all these core components in-house, the integration and optimization on the system levels can be guaranteed to support the simplified and the user-oriented workflow designs. And also very importantly, we across all UMR systems, we use the same design of the user interface and share majorities of the applications and processing platforms. So this is very important, and we'll see it later. So in this way, we are able to offer a one-stop cardiovascular solution from the pre-scan system calibrations to the advanced clinical and research applications, and all the way to the post-processing and analysis platforms. So let's take a look at how we tackle those major challenges. Firstly, the operational challenges lies within the complex workflows, which require specialized skills and experience to perform the scans. So on your MRI systems, we employed the AI solutions to the workflow on different steps that's time-consuming or lack of robustness when done manually. So for example, for the not field shimming, we use AI workflow to automatically select the optimized region for the shimming over the heart to ensure uniformity or highly uniformed not field distribution over the heart. So this feature does not require any manual interventions, and it is integrated with all the cardiac scans. And when it comes to the scale imaging, routine methods would require multiple breath holds and extensive knowledge to find the anatomy of the heart correctly. But with the easy scan feature, using only one single free breathing scale scans, which usually takes 15 to 20 seconds, one can directly get 7 different anatomical view of the heart, as like showing here. So for all following scans, one can simply set the imaging planes by directly aligning to any of these anatomical planes. So in this way, it is very easy for anyone to do the cardiac scans, and operator errors can be minimized. So as many of you may already know that we have United Imaging have this Jupiter 5T system, which is the world's first whole body ultra high field MRI. So this means on the 5T system, it also comes with the first ultra high field cardiovascular imaging package. So in last year's SMRA, we already given a talk on the 5T. So today we are not going to more details about it. What I'm going to show is that on the 5T system, except, apart from the AI shimming and easy scans feature, the 5T system also have a dedicated cardiac imaging B1 shimming solution, which includes a unique 8-channel volumetric transmit coil, and each channel can be individually controlled to achieve uniformed B1 distributions over the heart. So, all right, so let's take a look at a challenge on cardiovascular imaging durations, which generally suffers from long scan times and low success rates. So on UMR systems, by employing various AI-empowered technologies throughout the cardiovascular imaging workflows, such as the superflex coils, the easy scan, AI shimming, and improved sequence design and acceleration technologies, we have successfully bring down the total scan time of routine clinical scans down to like 15 to 25 seconds, depending on whether the contrast agents are used. So in these ways, the efficiency of normal cardiac scans in a clinical environments can be guaranteed. So for data acquisition acceleration, we offer a full stack of AI-powered fast imaging techniques, including the ACS, which is AI-assisted compressed sensing, to achieve high acceleration factors for data acquisition, and also the deep recon, which is a deep learning-based image reconstruction platform to achieve image quality enhancements with the artifact and noise reduction effects. So with ACS and deep recon working together, very high quality cardiac scans can be achieved with much improved balance between the efficiency and quality. So for example, for the whole heart Doppler imaging, routine para-imaging methods generally requires multiple breath holds and 2 to 3 minutes scan times. But with the ACS, similarly good image quality can be achieved with only one single breath hold or 14 seconds. So on the right show is the results from a study. We can see that the diagnostic efficacy on reviewing those edemas remain the same. Similarly, the single breath hold whole heart ACS cine is also becoming a new standard feature on the latest UMR systems, offering similar functional analysis outcomes as the traditional methods, but with much reduced scan time and therefore improved robustness. All right, next, let's take a look at the patient comfort issue. Apart from the long scan times, there are also many factors that can reduce the level of comfort and cooperations during the cardiac scans. So the first thing we do to address this issue is we have designed this SuperFlex coil family to offer comfort and convenience during the cardiac scans. The SuperFlex coils are designed with minimum to no hard components inside. So they are very soft to use and very comfortable for the patient. Most of the time, we just simply lie them on the patient, and it can simply automatically fit the contour of the body. So making them very simple to use and very comfortable to use. The SuperFlex coils comes with different sizes and shapes, and a number of them can be used for cardiac imaging. From the 48-channel whole body SuperFlex coil, which covers the chest, the abdomen, and the pelvis at the same time, to the normal size 24-channel body coil, as well as the 24-channel ultra high density SuperFlex neck and chest coil, which is more dedicated to the carotid and thoracic angiography imaging. So you can choose to use the one that best fit the needs of your studies. And recently, the Easy Sense is a new feature emerging in some of the latest UMR systems. By using a dual source millimeter wave radar integrated in the scanner board, it provides full-time contact sense and tracking of the respiratory motions, which can significantly improve the workflow and patient comfort when compared to the traditional breathing belts. Okay, another type of patient-friendly techniques are those free breathing ones. So with ACS, we can significantly reduce the acquisition window and therefore reduce the motion sensitivities, leading to high-quality free breathing image acquisition, such as the titulated Doppler and myocardial perfusion imagings. And also the real-time cine is also a very friendly solution for patients that have difficulty holding their breaths because of its free breathing and non-ECG gated features. But it also takes a few tricks to do the real-time cine properly. So with the with the SuperFlex coils and ACS techniques, up to 15 times acceleration can be achieved to significantly reduce the scan times. And AI-based motion correction can effectively reduce the artifacts and blurriness in the images and retain the sharpness of those images. And of course, the reconstruction time is generally less than 10 seconds to minimize the delay between the data acquisition and the image viewings. All right, so next, let's take a look at the analysis portion. Acquiring very good data is only half the work. The other half is on how to extract those useful informations from those hundreds and thousands of cardio images. And these challenges, lies in how to do it effectively and reliably. So on UMR systems, we offer a one-stop cardiac imaging post-processing and analysis solutions based on this U-Omnispace platform. The U-Omnispace platform is a full-scale platform that integrates all the post-processing and analysis tools for all imaging modalities, including MR, CT, and PET, and so on. So for the MR section, as we can see here, the cardiac is only a small portion of it. So with this one-stop cardiovascular analysis solution, we can offer automatic and semi-automatic processings for the cardiac functions, perfusions, viabilities, 2D and 4D flow, MR strains, as well as vessel walls. So because of the limit of time, we are not going into the details of these features. We have set up Omnispace in our booth, and if you haven't had a chance to check it out, you can just let us know and we can have that. All right, so lastly, let's take a look at the research aspect, especially when it comes to ultra-high field and preclinical animal scans. The quality and quantity and availability of the cardiac research package is rather limited. So as mentioned before, we maximize the benefit of maintaining the core structure of the software and applications across all UMR systems. So in this way, we are able to offer default protocol sets for cardiovascular imaging on both the 5T system and the 9.4 Tesla systems. So as an example, in this study by Shanghai Zhongshan Hospital, the coronary artery imaging results are directly compared between the 5T and 3T system, demonstrating the significantly increased SNR and image details 5T system, which is one step closer to the CCTA results. And also the LGE images also shows that the 5T can show more finer details of the infarction and fibrosis in the LGE scans. All right, so for 3 more seconds, sorry. So for the animal studies, we have performed cardiac scans on the PET-MR, primate scans on the research 3T systems, and this is the setup of the primate scans, showing very high qualities of the images, just like the humans. And for the preclinical systems, we can directly show the reveal those high quality cardiac imagings out of the box. And also we can do LGE, T1 MapCine using the multitasking techniques, ultra high resolutions and flows and so on. So, so for summary, yeah, last one, sorry. So for summary, United Imaging offers comprehensive and state-of-the-art cardiovascular packages over the UMR systems. And we are looking very much forward to working with the community to improve the vascular imaging. Thank you so much.
Thanks very much. We're going to have a brief question session. So will the speakers please come down to the table? Do we have some questions from the audience? Yep. In back.
Like on your slides, you show most of the images are 2D images, which probably have somewhat limited resolution in the slice direction. Do you think maybe the newer techniques that are 3D and maybe with isotropic resolution could make an impact for the scar characterization? What are your thoughts?
Well, first of all those acquisitions are 3D. The native T1 and the LGE are basically the same sequence. They're 3D scans, native inversion recovery, typically 5 minutes to 10 minutes. But that said, yes, of course, especially when you saw the patient scans, the images still look kind of cruddy. So yeah, work on motion compensation is going to be important. Obviously, in the presence of devices, wideband and the like, maybe multi-contrast will help us. I mean, it'll be nice to see that edema as well as the native T1, because then it'll tell you why you're getting non-inducibility. So I think there's lots of room for improvement on the technical side, but obviously what we're trying to show right now is clinical efficacy. But yeah, no, keep driving on the technical. We need it.
Great talks by all of the speakers. I have another question for Graham. Thankfully, this microphone is working because I can't shout as high as you've been. The workflow during the procedures, Graham, specifically for the late gadolinium enhancement, you detailed the native T1 imaging very well. What was the workflow, the timing during the procedure? At what point, if any, did you inject gadolinium to see what the effect of the ablation was?
Yeah, I guess the key message here is these studies right now are all, we're doing the scans after all the ablations are done, because we're doing the ablations conventionally. But as Aravindan pointed out, if you were, let's go to the scenario where you're doing a direct MR guided intervention. What we foresee is you would do the native T1 intermittently to see how you're doing. You would find the gaps, fix them. The challenge is once you got GAD on board, it's really hard to kind of go back. So what we believe what one should do is, find the gaps with the native T1 at the end of the study, do your LGE, because it's certainly the most sensitive technique to see everything. And it obviously has higher SNR, but you just can't do it multiple times very easily.
Got it. Thank you.
A question about MR lymphangiography, because I was very impressed with the images. One, do you think, you said standard gadolinium agents, but do you think there might be advantages to the new high relaxivity agents that have got lower osmolality and lower viscosity? And also, you're obviously an expert in a center that specializes in this. Would you think that patients should really come to you from around all of Germany or beyond to you? Or do you think there is a role for diffusing this technique to other centers that can do the imaging and then send it to you? And if that's the case, would you be willing to share how you do this?
Well, to answer the first question, obviously I haven't tried, and I don't think that it has been tried to do MR lymphangiographies on a larger scale with these new agents. Obviously, every agent you use is an off-label use. When you inject the contrast agent in a concentrated form, you can get problems with T2 star effects, so you don't see anything. So we usually dilute the contrast down depending on the patient, the age, the body weight, and the question we want to answer. So I don't know currently if you really have any benefit from using these other agents, especially you could save some gadolinium, especially in these small children, but we'll just have to see. The second question. I do believe that it's necessary to get at least some more centers on board. I don't think that it's something that's useful in every single hospital, as it's logistically complex, and the patients usually have quite individual problems. You have to adapt your technique to, so you have to have at least a couple of patients a week or a month to really improve your technique as we did over, yeah, I think we're doing it 25 years now. So, but we are, and I think it's the same in all centers that are doing it currently. We are struggling with the patient numbers. I personally see around 800 to 1,000 patients a year for these, and it's just getting a little out of hand. So I think the diffusion of knowledge is important, but we need specialized centers for the more complex patients.
Thank you. Congratulations. Good work.
Great talks. So one question to Christopher. So since clinically some patients who need endovascular intervention is very urgent, so could you comment how to make the pre-procedure planning more faster?
Just to make sure you're talking about the imaging of the plug and to the planning from there. Oh, okay. So you mean in general? Well, I mean, I listed some cases there that I'm familiar with because I've done it. I was involved in, right? And what I'm seeing is definitely time is an issue. So it's not something that you can spend too long on. And there has been in the last years really some progress to do this. I think it's going in the right direction. It's basically a combination of technology. And it's also then post-processing. I think it's very important to have the combination of both. I think the last speaker also alluded to the whole package that you need to do this, right? It's not done just by having the image, or it's not done just by then having some delay in doing some post-processing. Or, you know, what I mentioned throughout my talk was extracting the information in those images, right? That's really exist in the scan. And I think this is very important. And so at the end of the day, it's may not just be the scanner or the image, is maybe a whole team to do this. Now, how to do this faster in general, I cannot really tell you up front, but it's a little bit from my experiences, what I can report. And that's simply what it is. It's a close collaboration as a team together. And that usually goes a long way forward, you know, to improve that limitations that you.
I have a question for Aravindan and also for Graham, and that is, have you tried or have experience with cryoablations in the MR system, and do you think that has any advantage or disadvantage over RF ablations?
Yeah, so we've not performed interventional cryoablation studies. You know, I think in general, we know that T1 weighted imaging is not effective, you know, looking at the permanent durable lesions with cryoablation. I'd say that probably rather than cryoablation, more of the interest is towards this pulse field ablation. So, you know, irreversible electroporation. Certainly for atrial fibrillation, I think that's becoming almost a standard method, not so much for improving outcomes, but it significantly shortens procedure duration. So I would say rather than cryo, that would be more of the interest in seeing, can some of these techniques be applied potentially to pulse field ablation?
Maybe just to add to that, yeah, I mean, as Irvin mentioned, I think pulse field ablation is rapidly becoming the standard of care in atrial. There's still a long way to go in ventricular, which I'm somewhat relieved at because, yeah, we've been doing MR of pulse field ablation in preclinical studies. Check out the paper came out last year. Unfortunately, there's no thermal effect, and I convinced myself of that because there's no native T1 signal. So we're going to have to look at other techniques to look at lesions with pulse field ablation.
Yeah, I would just comment that, you know, for durable lesions for cryo, though, I think there are thermography techniques that might be useful for looking at durable lesions. But clinically, I think I'm using cryo less and less for arrhythmia. The main use for it is when you're close to the conduction system and we don't want to create injury. It's a slower form of injury, so you have time. You know, it's not necessarily irreversible injury when you start to see conduction problems. You can stop the cryoablation.
I have a question for any of the interventional speakers. You're dealing with arrhythmias, so what's the challenge in terms of getting good images dealing with patients with arrhythmias?
Well, so I will say that, you know, fortunately, many times for these ablations, they're not in active arrhythmia at the time of the procedure. So, you know, AFib ablation is generally a structural type procedure. And actually, we cardiovert patients generally at the beginning of the procedure if they are in AFib. even just to obtain the maps. There's a difference in the voltage characteristics measured when you're in AFib versus sinus rhythm. So we generally perform that type of ablation in sinus. And VT, generally, it's not hemodynamically tolerated enough to be in, arrhythmia continuously, certainly. But, there are patients who have PVCs or intermittent ectopy, and, that there is work in that type of thing. These motion correction techniques could be useful in that group of patients.
All right, so thanks very much to all the speakers for the excellent presentations. We're going to have a 20-minute coffee break and then resume with the closing plenary.